Stay tuned as the doctors follow mobility tonight on Call. Funding for On Call television is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call television as it continues to open doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Dakota Care, the Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, Dakota Dermatology, Aberdeen Asthma and Allergy, the Orthopedic Institute, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation. A basic ability that the majority of us take for granted, being able to move through and interact with the world around us. It can change with injury, disease, and age. We may be impaired for a short time or for life. Personal mobility, when the doctors are on call tonight.
Don't get around much anymore.
Hello and welcome to On Call Television. Tonight we speak to one of the most important issues for humanity, the individual need for independence and self-direction. Unfortunately, this so-called unalienable right can still be lost in this free country, and that is with the loss of mobility. With the advent of technology, we have made every effort to preserve the capacity to move independently. Medical help for the foot health, for development of artificial limbs, for advances with wheelchairs, even power chairs that bring a quadriplegic individual to go where he or she wants with remarkable freedom. These make mobility possible. Yet this precious freedom can still be compromised by falls, fractures, inactivity, and even our misdirected efforts to help. Tonight we have a rehabilitation doctor for the VA hospital in Sioux Falls, physiatrist Dr. Jim Hoff, and a reconstruction doctor for the Orthopedic Institute in Sioux Falls, orthopedist Dr. Corey Rothrock, to help us answer your questions. We are here live, here waiting your questions about mobility, independent living, and what we can do to preserve it. We invite you to be a part of this program. Call early, bring us into your home to help you and your family preserve your independence. Call in your questions or comments at 1-888-376-6225. Or you can submit them at oncalltelevision.com and click on the questions button. So Corey, let's talk about you. You are from Sioux Falls Orthopedic Institute. Where are you from originally?
Originally in Nebraska, and a Husker fan at that, I guess.
You're a Husker fan.
Yeah, tried and true.
So what town did you grow up in?
Clay Center, Nebraska, a small town down by Hastings.
Oh, really? How many in their town?
600, I think, about this time.
Ooh, Clay Center, Nebraska. And then where did you go undergrad?
University of Nebraska for undergrad, and then medical school in Omaha.
And then residency?
Yeah, residency in Orlando, Florida at a program, and then I did an extra year of training in New York City.
And what was that in?
In musculoskeletal oncology, in bone and muscle tumors.
Oh, yeah. And you've taken care of a number of my patients who've had cancer of the bone.
I have, yeah.
So I so much appreciate that. So how long have you been in Sioux Falls?
I was trying to do the numbers. I think of this as starting my 4th year at the Orthopedic Institute.
All right, great. And Jim, you've been around more than 4 years.
Yeah.
You're from where originally?
D. Smith.
Go Bulldogs. And so you went to what school undergrad?
USD. And then did medical school at USD. And then I did training at McKinnon. And then I went out of state. Been in Missouri, Wisconsin, Minnesota. Been around.
So tell me, your training is in physiatry. What is that?
Physical medicine rehabilitation. It encompasses a lot of different things. Essentially, you can end off working with amputees, spinal cord, multiple sclerosis, strokes, traumatic brain injury, to doing just pure pain clinic. So
you've been at the VA for how long?
13 plus years now.
13 years at the VA. And most of what you do has to do with veterans that are just back from the recent wars, or what do you do?
Well, I cover the spectrum. I think the average age is probably in their 60s, but yeah, I see a significant number that are coming back from the Gulf War, from actually first and the second. So it just depends what their needs are.
And what is your most common problem that you deal with?
Right now, actually, I got some help where I'm at. So arthritis probably the most common on there, and I'm assuming that's probably what you see also.
Yeah. So arthritis is a big deal. I mean, osteoarthritis, plain old rotten, trauma-induced osteoarthritis.
Oh, it's a gift that lasts for a lifetime, right?
Yeah. Corey, what is it that you do mostly? I mean, what is your biggest job?
The largest part is joint reconstruction, either of the hip or the knee. I do some of the trauma work that the guys in my group and the other groups don't do around the state, and then also care of the bone and musculoskeletal tumors in the state as well.
Yeah, that's an unusual kind of tough territory.
You know, it's rare. Bone and muscle tumors aren't that rare, but cancers that start out somewhere else often end up in the bones, and finding ways and specialized ways to kind of take care of those that we might have written off and kind of assumed weren't treatable before we can.
So in my sense, let's move to the topic of mobility. My sense is that it is probably the underlying important end result that we really want for everybody who has any musculoskeletal injury, is to try to get them back to function. And summarize it in your own words, Jim.
Independence, pure independence, mobility. You know, the disability and handicap to me are two different worlds. A handicap basically is an impairment that you have on there and limited, and disabilities are stopping you from doing things. I'm one of the guys that works with the staff of creative people under to open up doors.
Try to get them back to mobility.
Get them living life. That's kind of what it's about.
Yeah, I think motion is truly life. When you cease motion, most of that all stops. There's some things you can do in mobility, but without motion, most of that life stops.
Yeah. Well, I'm always amazed. I have a nephew, a step-nephew, who is a quadriplegic from a biking accident. Full speed college biking, broke the neck. Now he uses a straw to move, but he still moves. And we were visiting about a year ago, and he'd be going through his day, and then he'd bring his chair up and lean back and move the pressures off of his different parts to keep his the sores on the bottom from occurring, and make the movements that you need to do. And I mean, he just kept himself independent the whole time. It just blew me away. So we can find ways to do that.
Oh yeah, if you can think about it, you usually get creative. Some of the best things I ever learned are actually from my patients. I'll look at them and I go, like, you had plenty of time to think about this. How'd you figure this one out?
Yeah. So do you sense that the improvement in technology has been a true blessing, and how much technology has occurred?
It's opened up doors. I think the hardest part is being able to get the technology on there, depending on the insurance company, how creative they are. Some I have very Ocano type things to remedy it. Some things can get pricey.
Yeah.
But like you can get as fancy as home environmental units where you can control everything from the box to the lighting, the curtains, the doors, you name it. You think about it, and the technology's improved.
So, I mean, you can live at a home by yourself without parents or wives or family or whatever, independently, with emergency call buttons if you need them.
Oh yeah.
Yeah.
Yeah, I think if the technology's there, it's up to the individual, though, to make the most of it. And that's what your statement that you learn so much from your patients, they come with us and tell us, you guys need to do this. You need to figure this out. And a lot of the modern innovation, either in my specialty, all of our specialties, comes from them thinking about it and us trying to find a way to do it. But it's the individual that makes those things happen.
So let's bring it to the vast majority of our audience is probably an individual that is noticing that life is coming along, they're moving along, they're getting in an older phase of their life. What's the major risk? Well, I'll tell you what I think the major risk for those people is inactivity. And our society has brought us to be couch potatoes. The kids are taught to be couch potatoes. How can we in our society try to bring people to be more active? Corey.
You know, I think it does start with the individual and just showing them and opening windows early on. I think you mentioned the kids are is a great point, that we got to get the kids more active, and I think you see it from the pro athletes and starting Play 60 or the basketball athletes. All of those things probably matter, but the family matters too, to get them out, get them away from the TV. And I don't think the loss of mobility or the loss of activity really dawns on them until we see patients in the clinic and they think, shoot, I really wish I would have done this 10 years ago. And the quote-unquote golden years aren't so golden now for patients that have suffered those problems. So,
I keep thinking about those football players, that are just these bulky, big, powerful guys, and then as soon as they quit, absolutely killing it, they keep eating the same amount and they just balloon and then they're disabled.
Yeah. Dr. Dorr had a great saying for us. He said, as we age, everything we want to stay tight gets loose, and everything we want to stay loose gets tight.
Yeah.
So,
true.
I mean, it's so that's the goal, is to stay mobile, keep that activity going, and keep the ligaments, joints. Everything matters, for cardiac health and just being able to enjoy life.
Yeah, that's important. It does. Even if you're getting arthritis, you still have to maintain movement on there, actually. And if you don't, it does get tighter.
Yeah.
It does affect you. The normal walking lubricates the joints. It's very, very important. It cuts down on the stiffness. So they'll be stiff in the morning, and it kind of gets better.
I think the standard is that, okay, well, I'm getting osteoarthritis. It hurts to move, so I don't move. And then I have less pain, right? And the answer is, they've done the studies. The studies say the people that are moving, they have to move through the pain, stay more mobile, record less pain, do better. Even if it's bone on bone, they do better being active. Now, would you agree with that bone on bone comment?
Well, I would agree with it, but I think they'll tell you that this is hard. This is hard to do it, and I think you acknowledge, look, it is hard, and especially that second step. And our goal should be to try to get through those first couple of steps and get people headed in the right direction. Because patients, once they lubricate their joint, once they get moving, can do so much more. But it's that engine that just is trying to fire up that engine is frozen on the tracks, that you just have to get them going somehow, and trying to find quick interventions for that.
Well, they just tie together, though, because the less movement, if they're putting on more weight, the more weight you put on your lower extremity joints, and it just starts spiraling. And it sneaks up, and it may be 30, 40, 50-pound weight gain over time in a 10-year period, and it just kind of sneaks up.
The post-op knee is one of those things that really sticks in my mind. Person comes in, gets their knee replaced, okay, and they start out with a mobilizing deal. It moves their knee back and forth without, or it gets stiff. And then the physical therapy dives into it, and it's sore at first, but the better and the more they move, the sooner they're able to get out of it, or they end up with chronic pain. Isn't that amazing? The less they move, the more the pain.
Yeah, that's so true, and I think they fear that pain after surgery. And when you go through with them and tell them this is what life is going to be like on day 0, day 1, day 2, their eyes just get really big, like, you mean you're going to want me to do that after my joint? And then by day 14, they came back and they say, thank God you made me move those first couple of days. I went home, I sat around a little bit more, and now I hurt a bit more. You think, well, that's why we moved you so much in the hospital. It's not.
I've had studies when you go for 2 weeks, if you're just couch potato, you get atrophy. And for every day down, doing absolutely nothing, it takes you 2 days to get it back. Now imagine doing nothing over duration.
It's huge.
It doesn't seem like much, but it adds up.
I think the the reverse is true. That people think if they're not doing like a mile a day or 6 blocks or a number that seems sufficient to them, they think, well, then I might as well not do anything. And that's, I think, just terrible logic that go do 1 block today. let's work on 2 blocks next week and find some way to get this engine going a little bit.
Right.
I talked to him about time.
We need to commit ourselves to time. It is incredibly important to exercise in whatever way you are able, but when your exercise helps others at the same time, it's marvelous. Howard Lee of Volga rides his bike for exercise every day that weather permits. The icing on the cake is that he uses his bike to deliver meals for 60s plus dining to people who can't leave their homes.
As far as keeping in shape physically, at my age now of 94, working on 95, I sometimes have to, my balance is not the best in the house, but once I get on the bike, it's a whole lot better. People have trouble believing that, but I explain that actually when you're on a bicycle, the bike wheel wants to keep you upright. Now, my wife, Gladys, she does a lot of walking, but I have trouble with the walking because I had an accident and smashed my heel in a fall back in 1975. And I walk on the left side of my right foot. Biking doesn't bother the ankle at all, or the heel, but with walking it does. And even in the winter time, unless it's too icy, I would get on my bike, and I've got a carrier on the back side behind the seat, and I've carried at least 5 meals at a time, 5 or 6 at a time. And some people kind of laugh at the diligence that I have in making the rounds with that bicycle, but I feel better every single day if I ride that bike. And if I don't have a good reason to ride the bike, I sometimes ride it for no reason, just because I feel better at the end of the day. Even sometimes when you can sit around, and if you lounge for a while, you can have a slight headache. And you go out on that bicycle and pump the legs, get the blood circulating, and you get rid of the headache. Like Dr. Holm would say, exercise is a whole lot better than taking pills. In fact, one of the hardest things that I do is standing still. I want to ride my bicycle. I want to ride it where I like.
Isn't that a great story?
Yeah.
I love Mr. Lee is in his 90s, and he's bringing meals to people, and he's on his bike and staying active, and that's why he's in his 90s. Join our conversation and call in your questions and comments about tonight's topic. Call 1-888-376-6225 or email them to questions@oncalltelevision.com. Let's hear your questions. And we do have some questions, but I cut you off a little bit before, Jim. Anything in particular specifically you were saying? I think we were all talking about the value of moving to prevent pain.
Oh, what I was telling you, I end up talking to the patients about the amount of time that they look at. Aerobic conditioning, what I'm talking about, just using the oxygen. For long endurance training, you want to get past 20 minutes, and I'm trying to get them back 20 minutes. Ideally, to maintain weight and activity on there, hour a day, and it doesn't have to be all done at once. 10 minutes here, 10 here, 10 here, it adds up.
So you like the 20 minutes of aerobic, which is huff, puff, and walking fast, and then some strengthening.
Well, that, but just walking doesn't seem like much, but it does a lot.
It does a lot. All right. Well, we have a question from Mitchell, 89-year-old person, asked, discuss plantar fasciitis. Been very active a whole life now, developing plantar fasciitis. What can be done? Corey.
Number one thing, the plantar fascia, for those that don't know what it is, it's the tight ligament on the bottom of the foot, and that first or second step is just excruciatingly painful. That seems like the fourth, fifth get a little bit better as the foot stretches out a little bit. So it comes usually from muscle tightness, it comes from tight ligaments. A simple stretching program, sometimes wearing a little bit of a splint that stretches the muscles at night. is a great way to start the ball rolling to get it to go away. If that fails, there's some other treatments such as injections or possibly some anti-inflammatories or orthotics too. Sometimes it's a matter of how the foot strikes the ground. So
Right, it's that bowstring that makes the arch.
Right.
And where it attaches, it hurts.
Right. Yep.
Any comments?
Spring ligament, if you remember back to school. The arch gets inflamed. It takes a while, and you got to be patient with it.
It takes a while, doesn't it?
Well, the morning sucks, frankly. I mean, and getting up on there.
Yeah.
Once they get to moving, it will loosen up on there. The stretching will help. If it gets real bad, sometimes they'll curl the toes up and put it in a stretch at nighttime, which does help out.
Right. Yeah.
But the inflammation will recede. Depends how tough you got to get with it.
Yeah, I had it. I mean, you know, and I did it. I had it when I started to go further than I was regularly going. You know, it was getting ready for a half marathon. I'm going extra miles, and then suddenly, in the morning, or in the middle of the night, getting up to the cannon. Oh, ow, ow, and you dance all the way to the bathroom.
Yeah, I didn't know how common it was, and then flying on the Sky Mall, there's about 9 different products for plantar fasciitis in the Sky Mall magazine. I think, well, this must be bothering a lot more people than I see.
Yeah. You've never had it. Have you had it before?
Yeah, I did. It took me 6 months.
Yeah, it takes a while.
It does take a long time.
You
Yeah,
gotta
you
be
do have to
patient.
be patient. Yeah.
Yeah,
Yeah,
you do.
the average thing, you look in the textbooks, they'll talk up to a year, it can go.
Well, and I like arch supports because it takes the stretch off the bowstring. You know, where the bow is pushing and stretching the bowstring. If you have the arch there, it takes that pressure off that attachment. Wessington Springs, caller's husband had a stroke a year and a half ago. He's unable to stand or bend in the middle. Physical therapy hasn't helped. Could colonoscopy have had or worsened the problem? Any ideas how to help him? I would only say colonoscopy probably didn't have anything to do with the bend, having given a number of
Unless they
colonoscopies.
left something.
You left something, broke something. Unlikely that it's the colonoscopy.
Unlikely.
I don't think they left the scope.
No, the scope should have been. We should have been out of there.
Right.
But unable to bend in the middle or to. So I mean, he's lost his arching support, and it follows his stroke. Jim.
Depends on the severity of the stroke on there and the placement of it. And then I suspect probably some arthritis with us on that. I need to know a few more specifics, but a good therapy program it was tried evidently, I'd have to guess, on there. Probably further workup to really take a look at the problem would be helpful.
Yeah, I wonder if there's Parkinson's disease. I wonder if there's other kinds of ankylosing spondylitis or some kind of spondylopathy of some arthritis of the back.
Yeah, just as we all have our kind of niches and our specialties, and sometimes a fresh set of eyes taking a look at a situation can sometimes give some insight that wasn't there. Just because one physical therapy program hasn't helped, that may not mean that nothing helps.
So if, let's say the person had a stroke, is weak on one side, less mobile, and now can't bend, what would you do? I mean, and there's nothing more. It was the stroke-induced weakness that did it. What would you recommend?
Well,
Sit-ups? Arching?
they're probably not ready for that one. When you go through a stroke, it's a very set process. It's like learning to turn over, sit up, stand up, and then move.
Pretty
And
limited.
No, it's a very striking process when you're working with a therapist on there. And when you get it's a team approach actually when you're looking at it. I look at the medical problems if there's complications. Usually when you get involved, there's usually more than one issue. There's probably a few of them. And you have to tackle them.
Let's get some help. This guy needs to have some help. Get another opinion.
Get a fresh set of eyes on it, yeah.
Yeah, fresh set of eyes. Okay, we have from Vermilion, bone on bone in the big toe. Not bunion or gout, bone on the big toe. Short of surgery, what can be done? Do you ever get cortisone shots in the big toe? And what about the big toe?
You know, it's a high-stress joint, and I think we take it all for granted until you stub it or it starts to hurt you. But it does go through a tremendous amount of range of motion just walking, and it hurts. And short of surgery, anti-inflammatories, what we offer is just a is a little shank almost in any shoe that'll fit in any shoe, and it prevents the toe from bending. And so you can wear any shoe, but the toe won't bend. It becomes like a steel shank kind of shoe, and that takes a lot of pressure, and it's amazing how well people do with that, just by alleviating a little bit of pressure on the toe.
But if that toe is causing you so much suffering and it hurts so bad and it's keeping you from being mobile, maybe it's time to go to the surgery. I mean, the surgery's not that hard, is it? Or what do you think?
Surgery's not, well, I haven't had it, but have, you know, rarely performed it. It's not that bad, truthfully. And I think it is, whether it be a fusion or just removing the bone spurs that are grinding, it can be pretty straightforward, and it's such a dramatic improvement for patients that have it.
Yeah.
Well,
Jim?
if it's bone on bone and needs to be stabilized on there, I don't make a living sending people to the orthopedist. Occasionally it's needed. The shoe wear, you have to pay attention to that. You were talking about supporting a steel shank. I'll extend it out. The big toe is so important in the walk because it's the last thing that leaves the ground.
Oh, really? I mean, that really, without the big toe, we lose a lot of stability, don't we?
It changes your walking quite a bit.
Really?
Yes, it's important.
So you want to preserve...
I'm not advocating amputating it.
No.
Yeah,
No.
You know
No,
that.
no, but preserving the
Right,
function on
got
there. Some people fuse it. Sometimes they've got silex replacements that have improved tremendously now over time. But you think about it like the big toe of the foot, it's like the thumb to the hand. It gives you the opposition, but in guidance for the gait, it's important.
Sure, yeah,
Or
there
for
you have
walking.
it. Sort of like
Yeah.
it's the balance part of your foot. Well, and my sense is to get it fixed so that you can stay mobile. That's the key. There you go. It is amazing the strength that is generated when a person sets their mind to reach a goal. One man's accomplishment and determination is an inspiring example of overcoming the challenges that came with the loss of his mobility.
I went out after work one night and I got mugged and the assailant hit me in the right side of my head. The opposite side of my body is affected by the right side of my brain. So the left side of my body it's functional and I can feel it, but it needs to be retrained on how to do everyday tasks. I have been doing some light physical therapy and I do believe I'm making progress to be normal again. In the last 2 years, I've made progress in the aspect of walking myself. I can take about 3 steps by myself without assistance before I crash. I had to teach my knee and my hip how to do things. There's a lot of stuff I can still do, but I had to find a different way to do it. Everyone is dealt a hand in life. Sometimes you train a 3 to 4 and get a king release. Sometimes you train in a 3 to 4 and get a 23, but you need to play your hand as a adult and do the best you can with what you've got. I always dealt a good hand, and I thought I'd make it better, but it took some of my points away. But I can still take the hand I have and play the best of my abilities. For instance, I want kids a lot, and I was blessed with the news that my wife told me she is no expecting, and that's fantastic because now I have a goal. I want to work by myself before the kid does.
That's a great story. I mean, a man with all that commitment and that positive attitude, and we wish him the best, and thank you for sharing that with us. It makes us realize, those of us who do not have the disabilities, how glorious it is that we have them, and then when we lose them, we move on. And eventually, we'll all have those as we go along. Jim, any comment?
Oh, he's striving for independence on there. This guy's gone through a lot of intensive rehab on that. Actually, it pays off. The positive attitude has helped this guy tremendously.
Yeah, and boy, that's it. This positive attitude is everything.
Yeah.
Yeah, it really is. Join our conversation and call in your questions or comments about tonight's topic. Call 1-888-376-6225, or you can email them to questions@oncalltelevision.com. Let's hear your comments about that last story. I'd love to hear what you think. Well, now let's talk about some of the practical things that people need to know. One of them is, how far is that disability before I'd have that toe fixed, that knee fixed, that hip fixed, Corey? Let's talk knees and hips. When do you say it's time to have surgery? And then we're going to have the non-surgeon rebuff you and say, no, that's too late, or that's too early, or let's hit some.
Well, I'll bring up some of the common myths. So the two things I tell patients that the criteria to meet to have a joint replaced is, one, they should have arthritis or a condition affecting that joint that can be bettered by the replacement, and two, that it affects their quality of life, however they measure that. And I think we all have to take into some reasonable expectation that it impairs their quality of life. It's not about how much the x-ray has changed. It's not about how many cortisone shots they either have or haven't had. If they meet those two criteria, that impacts their life.
So they are, again, what are they?
They have a bad joint, however you diagnose that, and it impairs their quality of life.
Yeah, and I think I put it as, if you can't do the things that you need to do, you know, that you enjoy the most, then we need to move on. Wow. Jim, how do you put it?
It's about living. Activities of daily living and mobility. Most people will come in to actually catch me when their primary needs are not met. Getting to the chow line or getting to the bathroom, simple things that are primary goals every day that you have to meet.
Activity of daily living, that's ADLs. So, and what are they again? I mean, there's actually a list that is the ADLs.
Bathing, dressing, grooming, eating,
okay.
Primary needs.
Yeah.
On that. Mobility, get around the activities you need to do. I look at the functional capabilities. The human spirit actually endures quite a bit. I mean, I've got people will show up that can barely get 20 feet, and they kind of like, probably should have seen you about 5 years ago. Yeah. Get more aggressive, but a lot of them it's not too late. It's just, what are the key factors? I think the hard part is if they do need a joint replacement and they're not able to really care for themselves and their spouse covers for them quite a bit, and then they waited so long to the point that their heart won't be able to tolerate the surgery on there. Then I get more involved from a different aspect in opening up doors. Yeah. But their health does better the more they move.
Well, and I'd add this, and then I'll throw it at you. So a person wants the knee to be replaced, but when you replace the knee, you've got to be able to have the muscles around it to work the knee, or you're not going to be able to rehab. So you don't want to go so long that you lose all your muscles. Now, I'll throw it back at you.
Yeah, it's a great point. I think we obviously see see them when they've had some impairment, but you just don't want to let it to be a old person, multiple bad joints with bad health. It's hard to correct all those things. So you kind of intervene not at the earliest, but when it's impacting. It brings up the term now prehab. So, you know, rehabilitating yourself prior to any surgery. And it's such a huge part of getting people to do well with surgery. And they almost take it to the limit of, how many weeks before surgery do I need to do this and start moving? And I say, what would you possibly wait for? Start today. You know, even if you don't have it replaced. I mean, today, when you leave here, just walk.
Now.
Yeah.
Actually, with society on there, the more knowledge really helps them quite a bit. Expectations, what do you need to do? And I tell them to be successful, this is what you're going to have to do. Actually, they worked on my knee. And it gets to the point you can expect sometimes about a third that I talk to, you have a little numbness here, but it won't affect anything you do. But the movement and restoration of your function is what you're looking for. What they put into it, and I don't mean to be bad about surgeons, but I tell them, anybody can lie down for surgery. The real work starts with the rehab on that.
Or the prehab. Before you get the surgery.
The prehab's important.
The prehab. Yeah, that's it. But you got to have a good surgeon to be able to do it right. I mean, you know.
Well,
I wouldn't have you do my knee. I'd rather have he would do it.
You know, it's a short surgery followed by a lot of therapy. It's a great point, and there's a lot of great doctors that can do it. And I think people have sometimes some unnecessary fear about what a joint replacement is and how painful it will be and what they'll have to go through from a rehab standpoint. And they ask, am I too young? Am I too old? You know, is it going to hurt too much to have it done? And just taking care of those fears one by one, I think, helps them do better.
They look at age a little bit on some of the guidelines, but I look at functionality on there because, I mean, if they're not living life or they can't do things in quite a bit, I mean, to a severe pace, you need to be doing something about it.
Well, and you've got to be able to see that they're going to be able to do something later. I mean, some are so disabled from a stroke or from memory issues or whatever it might be. You have to realize, where are you going to be after the surgery? How many months do you have of functioning after that? Are you losing ground for some other reason? So it's a balance of, it's the art of medicine, knowing when to encourage someone to go for surgery or not.
Well, everybody then who backs out, we said no, not everybody, but it's educating them, and you know, I don't think people realize that they let pain go on so long, assuming they have bone-on-bone arthritis. Then when they show up, we can sign them up. And what they have to understand is, a lot of the criteria now, they have to do 6 weeks of physical therapy. They have to have certain things that they've actually done and tried non-operatively before we even can consider doing it. So I think it matters to educate those people, and Dr. Holm does a great job of educating them too, and getting to the rehab specialist too, see what they can do.
The rehab specialist, that's you, right?
Well, rehab starts before, shortly after, and rehab expectations, I tell them they're going to be working themselves and educated up to a year to get the muscle strength about equal.
Winter, South Dakota. Caller has a major arthritis of her feet. It's wise to get surgery to be able to better function. We sort of answered that.
A little bit. I think for feet, I think the orthotic has just been totally overlooked, and I think
the orthotic meaning one that forms to the bottom of your foot.
Well, and I think they assume that with all the modern tennis shoes and everything, they can go into Shields and just pick one that'll solve all their problems, and they can't. I think they have conditions that would be made better by sometimes a custom orthotic, or finding that right fit and being guided on that shoe for what they need.
And you've got to have a good blood supply to that foot for it to heal too. That's the other thing. And I'm going to interrupt.
Well, I know, but depending if there's a lot of deformity to the foot or a lesion on there, is surgery in their interest, custom orthotics in their best interest for mobility on there. There are some modalities that probably shouldn't get the surgery. There are some that actually could be remedied quite a bit with it. It just depends on your case.
Great. A broken bone will heal faster in people who are more active than those who are sedentary. This goes for any injury that happens after a serious fall. Maintaining an active life is the best prescription for your overall health.
With the aging process and mobility, it's quite often that people lose some of their function and some of their independence if they don't keep moving. And like the old saying is, I guess, if you don't use it, you're going to lose it. And we find quite often that after an injury or a fall with the elderly, they sometimes are impaired with what they were able to do before. It's like arthritis. I mean, people stop moving their joints and they stop doing their knee kicks because of arthritis and pain. But in the long run, that's probably the worst thing to do, because you need to keep that movement going with them to get, you know, a little more longevity out of the joint. The people that are more active are going to bounce back quicker and respond quicker, and they're probably going to be more motivated because they've been disciplined to have exercise in their life and mobility in their life. We find that they probably have a better chance of getting stronger a little quicker than the average person that might not be quite, is maybe a little more sedentary and not quite as active. And quite often I would say that after a fall and a hip fracture or pelvic fracture, an elderly person would probably need about 4 to 6 weeks to get back to close to where they were. I don't want to say they're going to maybe get 100% back to where they were, but by that time it should give you a pretty good idea of what they're going to be able to recover with and continue on with the rest of their life and their independence that they're used to having. I think the most important thing about the mobility that they need to recover from is it affects the rest of their health throughout the rest of their years. I mean, it's a pulmonary issue with lung capacity, it's bone density. We're talking that any health issues they have, they're probably going to bounce back with quicker because they're stronger and they're more mobile. If they do get knocked down with something else, they're probably going to recover from that quicker too. It may be that they have to go through a phase of physical therapy and use a walker for a while, and then maybe wean to a single point cane and maybe eventually not even need an assistive device. The important thing is whatever can keep them mobile and keep them going is in their best interest to continue with.
Well, I asked her which patient should we use, and she said this guy, and we use that gentleman as our example because he's the hero of the hospital. I mean, he's done great. He's got energy, and he's really put it to the rehabilitation. So we thank him and we thank her for Karen for giving us a good example of rehabilitation after a hip fracture. We do a fair amount of hip fractures in our hospitals. There's no question about them needing to go to surgery because it allows them their mobility. Any comment about hip fractures?
No, I would agree with that. I think a safe surgery can be done and getting them up and moving.
Yeah.
Faster they're moving, the better their health and outcomes come.
So it's interesting, there's a lot of variability about amount of back surgery in the country, amount of hip surgery in the country, knee surgery in the country, but when it comes to fractured hips, it's uniform across the country. The people need to have their hips fixed when they fall and fracture. What we need to do is prevent falls. I'm going to ask you now, I mean, there's a lot about falls in the elderly. Any particular take-home message about falls?
Good assessment for assistive devices for walking or gait on that. It may be a walker, a rollator's kind of a walker with a chair in it.
Chairs.
Canes, forearm crutches. If they have the muscle strength but the balance issues, that can help remedy that.
So whatever you can do to keep walking, that's the key. And if you need some assistance so you don't fall, then get the assistance and get walking. We have a call from Sioux Falls, 74-year-old with both knees replaced. I wish I would not have waited. Strongly encourage people to get surgery. She is turning 77. It's a good comment.
I hope she's my patient. I'd like to think
we love to hear those words of support. Caller lives in retirement home in Sioux Falls. They exercise in the morning together. On Saturday, they do yoga. Exercise has kept me feeling great. Comment about exercise. Well, you've said it.
I feel better when I get exercise and walking regularly on there. You spiral. Couch potatoes don't help you.
They don't do very well?
No.
Comment from Sioux Falls. Lymph system is activated by movement. Do you have to keep moving to keep the lymph system activated? Corey?
I think it helps. I think there's some tricks you can do without moving, but certainly mobility helps. And once we can get that movement and that muscle contraction going, there's nothing like that to overcome that.
You squeeze the juice out of your legs. Jim?
It's helpful. Depends on if there's complicating effects on the lymph system. movement normally in a normal system, yes, it augments it, it helps it.
Yeah, so most of the time it does, although there's a lot of it depends. That's his big story. I
Well-
always hear this depends thing from this guy.
And I'm not wearing them yet.
No.
So, okay, but you know, if they have radiation on there, it sometimes can give them lymphedema on there.
And-
so that's a quandary on there. But in a normal working body, yes, it helps.
Yes. From Brookings, a rotator cuff surgery that was unsuccessful, muscle was not reattached. What's the next step?
I really think it depends on the impairment. What we had previously was not a very good option, and but there's been newer surgeries that kind of repair or replace the rotator cuff to turn the shoulder back around and kind of replace it in a different fashion. Sometimes it's muscle transfer, sometimes it's just different physical therapy exercises to maximize the health of the tendon or whatever is there, and try to do it in a safe way. So just depends on the disability, I guess.
I would say that one of the greatest changes in the last 10 years in medicine is shoulder surgery, because prior to 10 years ago, it didn't seem to work very well. I mean, nothing seemed to work well for the shoulder. Boy, it does a lot better now. Jim, you have a sigh. It's still hard.
It's still very hard on them. The rehab efforts have improved on there, and the techniques have actually gotten better with some of the aspects of it, but I'd have to defer to your expertise on that.
Yeah, I think they have gotten better. I think we're intervening early. Instead of waiting until it's just a dead muscle and destroyed tendon and you're trying to repair them. And so I think we're being able to choose ones that would do better with repair versus not repairing those that can't. We have some more advanced surgical reconstructive options from what's called a reverse total shoulders to make up for it. So they are better.
But if you don't keep those muscles working and you have no muscles, there's nothing to reattach.
Yeah.
You've lost it. From here in water aerobics, it takes care of joint pain and arthritis. Water aerobic comments.
I send people all the time for instruction on there. That's probably, if you have lower extremity joints affected on there, getting in the pool, the buoyancy takes the weight off the joints and you can strengthen your muscles. If I had a pool for every town, I'd put one in.
It's huge.
Yeah.
Yeah.
I mean, but not that if you have the ability to walk, that's the key. But if you're so disabled that you can't do a significant amount of walking, I would say that water aerobics is the big thing.
Well, a lot of people that are in advanced stages on there, I'll start them in the water, and then if they get to moving a lot better, I get them out of the pool.
There you go. Tingling. What about tingling in the fingers? They're still movable, but they tingle. Think it's carpal tunnel syndrome?
If I had a nickel, I'd bet on that.
There's a ton of it.
Yeah.
There's a ton of that. What can caller do about a trigger finger that locks up? When her finger locks, she has to use her other hand to straighten it.
It's probably, if it was just a simple kind of catching now and then, sometimes there's some anti-inflammatory or some stretching. If it's locking to the point of needing the other hand, it's probably time for a little cortisone injection.
Yeah. And there's surgery.
There is surgery if it fails. Cortisone's often effective, so.
It usually is. I'll get them, prevent them on there. If they're still locking and I can't free it on there, then I have to send them.
Quickly, back surgery 5 years ago, receiving steroid shots, now may need surgery again. Should he continue the shots or do surgery? What do you think about recurring back surgery? Ooh.
Well, I think they are tricky. I think it's, there's been a debate about how many epidural steroid injections and if they do kind of set people back and cause more harm. But the back surgery is a difficult.
Oh, it's a difficult bailiwick. Don't do it for pain. Do it for function.
The thing I can say that helps you sort this is the number of injections on there. You only stick to about 3 a year if it helps you.
All right. We'll be back right after this.
The flu bug is getting ready for another season. Are you? Get vaccinated, because stopping the flu starts with you.
This is a lesson for kids of every age, for babies and toddlers, for teenagers and young adults, for older adults, and even the very old. Daily movement and physical activity improves the quality of life for anyone who finds the discipline to walk. And if you don't use it, you lose it. If you ask any of my patients, many will tell you I sound like a broken record that keeps repeating the same exercise recommendation. Well, I'm sorry, but over the years I've been convinced that with few exceptions, no matter what age and condition, no matter what size and shape, daily exercise, daily, is the single best thing we can do for ourselves. Although the advent of power chairs has been a godsend for many very disabled people, these mobility helpers can be a harmful thing for the borderline disabled who would benefit from having to walk. I observed one elderly person who purchased a used battery-powered chair despite my recommendation against it, and I watched how he became weakened and then very disabled over just 3 months until his family realized what it was doing to him and took it away. And then, like magic, he came back to being a mobile person again, while not dependent on the mobility aid. That real story clarifies the powerful need we all have to keep moving today and every day. Discussing independence and preventing falls with a physical therapist, yesterday she spoke about the value of core strength to prevent loss of balance. These are important issues, especially for those who are in the retirement years. I asked her which exercise would help that core strength and balance best, and the answer was daily walking. Say it again, daily walking. One gentleman shared with me yesterday that he finally began the exercise program advised and was pleasantly surprised how much better he felt and how much he has enjoyed the daily 2-mile walk with the dog. Walk even through this cold winter sub-zero weather, but you need to dress warm enough, he advised, and your dog will enjoy it too. I walk today so I can walk tomorrow, my 95-year-old Aunt Audrey exclaimed. Those were her actual words, and although she's been gone for a few years, her encouragement to stay mobile has been the perfect theme song for a geriatrician caring for the elderly, and for people of all ages too. So don't lose it. You just have to have discipline to walk today and every day. We've got a few more minutes. A call from Huron, daughter, 63, active, kneecap, broke, healing good, can't get strength back. What can be done? Does physical therapy help?
Yes.
If it continues on there, they can look for nerve damage on there if they've gone over a reasonable period, but PT would be recommended.
But, I mean, what do you do for nerve damage? More PT? I mean, is there a nerve surgery? No.
You have to figure out what expectations are if there's something markedly wrong.
Right. Corey, any other comment?
Yeah, it's just it takes physical therapy both post-injury and your point of that, it continues a lot longer than the 6 weeks or 8 weeks of a fracture healing, and that's not enough time.
Had 2 hip replacements, one in the left, then on the right, now having knee issues. Are knee replacements often needed after a hip replacement? Ooh.
Tough question. It depends on the severity when you get into it, but sometimes I've had some where all 4 joints, the other joints that got replaced started feeling so good, they started noticing the other problem.
Yeah.
Your experience?
Yeah, it happens. You know, the osteoarthritis bug affects multiple joints, and it's not usually just one injury. It's something that they can do, and then one worn out joint leads to another worn out joint eventually. So that's why we try to address it early.
Or sometimes it was the knee all along, the hip got fixed, and then the knee Now we've got 15 seconds. Take-home message. Corey.
Any sort of mobility, even for the arthritic joint, changes the amount of pain that people have and keeps them out of our office until they really do need surgery.
Jim?
Movement affects your heart positively, your lungs positively, your weight positively, and it keeps you moving longer and your muscles strengthen.
Well, this is right on the mark, you guys. You're echoing what I think, and I thank you for that. It brings this to the end of our show this evening. I sincerely thank Drs. Jim Hoff and Corey Rothrock, our guests and friends, for helping to answer all the insightful questions from our audience tonight. It was good advice from the great entertainer Dolly Parton when she said, "If you don't like the road you're walking, start paving another one. Until next time, stay healthy out there, people.
Funding for On-Call Television is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On-Call Television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Dakota Care, the Brookings Health System, Dr. Mark Bubak with Dakota Allergy and Asthma, Dakota Dermatology, Aberdeen Asthma and Allergy, the Orthopedic Institute, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.